and thank you for joining the Superior Health Quality Alliance Roundtable conversation. My name is Kim Heft, and I am joined by my colleagues, Kelsey Ostergren, Jerry Hineker, Elena Baer, and as well as our guest speaker today, Dr. Buffy. For those of you that have been joining these meetings over the past months, welcome back. We host this session each week, which is a 30-minute educational session where we highlight important topics related to COVID-19, vaccinations, boosters, and other nursing home hot topics. One thing I'd ask is that if you can think of anything that you're struggling with, or maybe you're trying to figure out and you think it would be a good topic for a future event, just drop it in the Zoom chat and maybe we could use that as a session for a future session. And we just did that last week with our beers. So thank you to that person that sent that suggestion. Now, there will be a survey at the end of the session, which we would really appreciate it if you take a few minutes to complete. And Jerry's going to be putting the link for the PowerPoint presentation in chat momentarily. Please use that chat box to share any comments, questions, anything that pops into your mind during the presentation. And then we're going to use that for discussion in our Q&A session. And actually, talking about sessions, next week, our session is What Can Your QIO Do For You? You're going to be hearing from some of my colleagues and again, everything that we can help and assist you with in your nursing home world. With that, I'd like to welcome back Dr. Buffy. This is her third presentation of a 5-part series in infection control practices. And today's topic is infection control concerns and tips for transmission-based precautions. So with that said, take it away, Dr. Buffy.
Thanks, Kim. Thanks everyone for being here today. I appreciate you taking time away from your very busy schedules to participate. It means a lot to me, and I know the panel as well. So let's dive in. I've set my timer so that I don't go over, and so we have plenty of time for discussion. As Kim mentioned, this is your meeting, and so I'm going to present some education based on what I feel is relevant and see in the long-term care industry. But know that any questions that you have, I'm here to help support you and answer those questions as well. So I first want to, let's see if we can go here. The objectives today, I want to review the infection landscape in long-term care. If you are new to this series, this is important for me to do because it's what motivates me and keeps me working as an infection preventionist epidemiologist in this industry. So I want to review that with you. And then to discuss the difference between standard and transmission-based precautions, as well as some tips that you can help implement, not only for your staff, but your residents, to explore tips to implement safe and effective transmission-based precautions. So we're going to dive into that a little bit further. So let's talk about what the problem is and the landscape of the infection control in long-term care. So there are an estimated 1 to 3 million infections that are occurring every year in long-term care. That number is so big. It's so big to me. And, typically when we're looking at this grand scale, it's hard for us to wrap our minds around this. So I want you to take this number and take it into your facility and think about what your monthly infections are, or quarterly or annual infections are, and just then imagine your infections and then times over 16,000 long-term care facilities in this country. And so it really is a great challenge that we have. These infections are estimated to lead to 380,000 deaths every year, which is over 1,000 deaths every day from these infections. And what is important for me to tell you is that these estimates and statistics were before the COVID-19 pandemic. And so we now know these actual numbers are going to be even higher. We know the infections are the most frequent cause of transfers and hospital readmissions. And, when we're talking about value-based purchasing and we have outcomes driven to reimbursements, this really matters, not only from a prevention of harm to our residents, but also to, reducing our payments is a big deal. These infections lead to 150,000 hospitalizations. They cost our healthcare system 673 million. Again, these are estimates. I would anticipate they're probably low. And up to 70% of infections are preventable. This is what the research tells us. To me, that's like, okay, let's stop the presentation and just talk about that, because everything that we're doing is because of this. The fact that potentially up to 70% of our infections are preventable, that's what drives me every day. That's what drives me to do better, to help educate, to see what can I do to protect residents, and knowing that we have so much opportunity to prevent these infections. Now let's introduce, of course, COVID into this mix. And as a result of COVID, we've had over 200,000 residents and staff have died from COVID. And then along with that, as far as the infection control deficiencies, 82% of inspected nursing homes have had an infection prevention and control deficiency. That was from 2013 to 2017. And in 2020, the immediate jeopardies, or IJs, tripled from the year prior. Now, I don't like to ever lead from a survey perspective, but nobody wants any deficiencies in our facilities. And so please know that everything that I come to you with not only, again, helps to reduce the harms of these infections, but helps increase safety in our facilities. It helps us to pass our state surveys. It helps to reduce hospital readmissions. All of this in our infection prevention and control program. It's very important. So let's dive into what these transmission-based precautions and standard precautions are. I know this is basic knowledge in some regards, so I want to take us through the review. And I also hope that you will take these slides and utilize them in your facility and conduct an in-service training and even expand this knowledge, because there are staff within your facility that, even though they may have been trained this early on in their tenure with your facility, they may not really be practicing these basic principles. So for standard precautions, we know we practice standard precautions at the basic level. It's our basic infection prevention and control practices. We will utilize standard precautions for all the patients at any time. And it's really, an opportunity to keep us safe from harm, as well as other residents in our community. We use standard precautions to reduce the risk of transmission of microorganisms. Those that, we can't see microorganisms. That's the hardest part about our job. But it helps us we see the outcomes, we see infections, but maybe we can't recognize sources of infection. And so that's where, of course, hand hygiene and glove usage and even gowns and other types of PPE and standard precautions are needed. So this applies to blood, bodily fluids, secretions, excretions, whether it's visible blood or non-intact skin and mucous membranes. Standard precautions include practicing good hand hygiene. Now, we talked about hand hygiene practices in our first series session. And so as a reminder, and I'm just going to throw this tip out to you, how many of you have hand sanitizing dispensers inside of every resident room, as well as outside of every resident room if possible? This is a CDC recommendation, and it's really the most effective way that we can prevent the spread of bacteria and viruses and those microorganisms. It's through our hands. So hand hygiene is so important. Making sure we have the proper personal protective equipment, the gloves, the gowns, the masks, and the eye protection, that they're always available for our staff. Do we have easy access on each of our hallways, or do our staff have to, go to the basement, or do they have to find somebody with a key? I know that was definitely challenging when we have been locking up our PPE supplies when we didn't have a lot. But what about now? How easily accessible are our PPE? We want to make sure that we keep these supplies close to the resident care locations. So for example, do we have a good supply of gloves in our resident rooms, or do we have to go and find them? We want to ensure that for our bloodborne pathogens, to reduce the risk of a bloodborne pathogen, to use safety engineered needles, including lancets for testing blood sugar, and safety pens for those insulin pens. For the motto for safe injection practices: one needle, one syringe, one resident, one time. These are all our standard precautions. When we have our cough, always coughing into the sleeves and wearing a mask, or when recovering from a cold or cough. Now, I know we're all wearing masks in our long-term care facilities as source control. And so it's definitely helping to reduce the spread of influenza and other cold viruses as we are using the masks as source control at this time. So what are some tips that we can provide for our residents? Many times we think that, well, it's just for us healthcare workers or the staff within our healthcare facilities, but what about our residents? Involving them in the process and having a culture of infection prevention helps to really reduce the risk of spreading those infections, and keeping in mind always what those statistics are, right? So I want you to think about that. If we can reduce them, here's some ways we can do that. We can explain to the residents what the standard precautions are and why we use them. Many times if we come up to a resident, and not so much anymore, of course, because we're in with the source control, but if we come up to them and maybe we have gown or gloves or masks on, it kind of is like, oh, what's going on, and that it might make them feel like something's wrong with them. So explaining, that we're keeping everybody safe. Reminding the residents not to feel offended or afraid is really important. Explaining to them that it's actually the law that requires us to use safety lancets and needles to prevent the needle stick injuries. And then also, with the respiratory etiquette, explaining that the mask is worn to prevent the spread of germs. And it's very difficult with our residents many times to wear masks. But what I encourage you, especially if your facility there's no residents that wear masks ever right now, I would encourage you to go back and look at that practice, because I am in buildings all the time. And what I tell you is, if you have this culture and you really create it with the residents too, it is possible for the residents to have acceptance of wearing the masks as well. I've seen it, I know it's possible. So I would encourage you to continue to encourage your residents to wear that mask when they're in social gatherings, when they're close together. Obviously, if it's appropriate for them in their physical conditions as well. We want to help the residents practice hand hygiene. We need to offer them, this is actually a federal requirement, to offer them hand hygiene before they eat their meals, and then after using the toilet. Specifically before meals and after using the toilet is what our CMS regulations require. This is one of those areas that's often missed, especially offering hand hygiene before meals. And so this is a way that we can practice those standard precautions and keeping down the risk of spreading the infections. So as we shift over to transmission-based precautions, we have contact, which can be indirect with an inanimate object, a table, a light switch, or direct with that actual person or resident. Droplets are large respiratory particles that travel short distances up to 6 feet. We're all very familiar with droplet and contact precautions. Airborne are small respiratory particles that stay suspended in the air. Typically, we don't care for residents with infectious diseases that are airborne, such as tuberculosis, but COVID changed all the rules for us. And so we know that SARS-CoV-2, the virus that causes COVID infection, actually can be contact, droplet, and airborne. And so this has been a unique situation, of course, for our long-term care. And enhanced barrier precautions. I'm very well aware of the CDC recommendations that came out last week. I'm happy to discuss that in our conversation today, but knowing that the whole industry is kind of up in arms about this. And so I anticipate potential change when it comes to the recommendations for enhanced barrier precautions. So for transmission-based precautions, we want to adopt a person-centered approach to practicing wearing PPE. We really need to have it in our practice that we only have our residents on isolation or quarantine for as long as necessary. The unintended consequences can be quite severe, of the having our residents on longer than necessary. It affects them physically and emotionally, and it really can create harm. And so we want to isolate them the least amount of time as possible. A quick tip related to COVID right now. Last week I was in Minnesota at a number of facilities, and I was surprised to learn that some facilities are still automatically putting the residents on a 14-day quarantine if they're not vaccinated and if they're not up to date. And this actual guidance changed earlier this year to where we can reduce that quarantine time. So we test on day 1, day 5 and 7 or 7. If they're negative, both negative tests, then they can come off of quarantine at day 7. This is really important. That takes a whole week off of being on quarantine, and it saves your staff the time and the supplies of having to wear the N95 respirators and all of that PPE for those residents. They also, if they test negative, you can also have them off of quarantine day 10 as well. So it's day 7 or 10, but the guidance is no longer to keep them on quarantine for 14 days any longer. So hopefully if any of you still have that in practice, you can put that into effect immediately, and that will help ease the burden of not only your residents, but your staff. For contact precautions, we want to use it for known or suspected infections that are going to be transmitted through the contact transmission. These are some examples: MRSA, VRE, C. diff, ESBL, and CRE. Some of these multi-drug resistant organisms, when they're colonized, they may also require enhanced barrier precautions, but we'll talk about that in a minute. But for these, this is more for an active infection. And we would want to utilize contact precautions. What's really important is making sure you have an appropriate sign outside of the resident room that states contact precautions, or for C. diff or norovirus, you can even use enteric-based contact precautions, which clearly states on the sign that for those infections, you want to wash with soap and water first. And so that's important, especially for C. difficile. So there's some examples of those contact precautions. This is helpful, like I said, to print out and to have available for your staff, because we all know outbreaks happen at 3 o'clock on a Friday. And so sometimes it helps to have a list for our staff that are in the facility, exactly what type of precautions they need to go on. These are just an example, but consider creating a list, laminating it, and putting it at the nurse's station so that they have a good list and understanding. So when they have this suspected infection, they have this handy tool available, as well as the signage available for them to put up as well. Again, for contact precautions, there's direct contact, which means that it involves the body to surface body surface contact, and physical transfer of the microorganisms between a susceptible person, which is the host, and an infected or colonized person. This is often what can occur between a healthcare worker and a patient, also and patients between patients as well. Indirect contact involves the susceptible person, which is the host, with a contaminated object such as needles, dressing gloves, or even unwashed hands. As I said in here, poor hand hygiene is the most often cited as a cause of contact transmission. This is true for our hospitals as well. The reason this is so is, and the reason hand hygiene traditionally is so poor is because of how often we actually need to conduct hand hygiene to effectively reduce the risk of transmitting these infections. You know, we're pretty much hand sanitizing all the time, and that takes time. It affects our skin. And so there's reasons why we're not just not doing it because we're trying to be non-compliant, but it can be difficult. And so utilizing some of these other measures too, wearing the proper gloves and the proper PPE definitely helps support this as well. We want to ensure that appropriate patient placement is made when we suspect or have a resident that has an infection that requires them to be on contact precaution. So for example, a private room is ideal. This seems to be, it's kind of it's a good and bad. It's a good thing because we have more beds available. It's bad because we have low staffing and we can't fill our beds, but that's kind of this catch-22 thing. But I'm finding more facilities are able to, because we have these open beds, we're able to have more of the private room. There is guidance, and I do have a link to the CDC transmission-based precautions. Feel free to use that and dive deeper into this content. But there are provisions available if you're not able to put a resident in a private room. We can cohort with the same infection. It's similar to what we do with COVID. There's also, we don't like to, but if you had a resident that needed to be cohorted with C. diff, then typically the resident with C. diff would have access to the restroom. The uninfected resident would have a bedside commode because typically there's explosive diarrhea and you don't want to be sharing, you would want the infected person to have access to the toilet. So just some ideas, but definitely if that's your situation, I would follow exactly as the CDC has it outlined in their information. Of course, we want to wear gown and gloves for all interactions within our residence. We want to don our PPE prior to going into the resident rooms and doff the PPE prior to leaving the resident rooms. This can be confusing sometimes, especially now with our source control for COVID, where we're wearing eye protection and an N95 respirators. If you're in a situation where you're needing to wear all of that based on the risk of COVID, then you would doff your gown and gloves inside of the resident room because it's considered contaminated. So having a trash receptacle inside of the room with a lid is what you would need. And then when you leave the room, you can then discard the eye protection and the N95 or clean and sanitize the eye protection as your facility policy has. You would not, if you're in a room that potentially somebody has COVID, you want to keep your mucous membranes, your eyes, your nose, you want to keep all of that protected until you left the room. But typically just contact precautions, everything gets doffed inside of the resident room. This is really important to educate visitors as well. Prior to COVID-19, one of the most cited deficiencies was family member, and for IJs actually, was family members, visitors leaving or not wearing PPE inside of a C. diff room or then leaving with it on too. So we really want to make sure we're educating our visitors on the proper usage of the PPE as well. And if possible, use disposable or dedicated share resident equipment, such as the blood pressure equipment. If this is not avoidable, then you want to make sure that you have a proper process in place for cleaning and disinfecting the equipment before it's used for another resident. And I really do challenge you on how this is being done, because this is one of those areas that I see tremendous gaps in, the cleaning of the shared resident equipment. It is one of the most common missed areas of infection prevention that I personally see. And so we definitely want to prevent the transmission of infections if somebody is known to have an infection or suspected. And so if possible, try to use the dedicated or disposable for that resident. And then if not, make sure that there is really good education for the staff for cleaning the shared resident equipment, as well as easy access to the cleaning agents. Make sure they're they're either on the actual Hoyer lift or blood pressure cuff machine or whatever you have, but that it's easily accessible, that they don't have to go find it where it's locked up somewhere. Another tip is for our housekeeping. You can have them clean those rooms last, because then the risk of transmitting to another room is decreased. For droplet precautions, this is for residents with a suspected or known pathogen that are caused from the respiratory droplets that are generated by coughing or sneezing or even talking. We're all very familiar with this now, again, with COVID, but here are some other types of droplet infections that are generating the droplets. You have whooping cough, influenza, adenovirus, rhinovirus, and group A strep. So these are important to make sure that the healthcare workers wear a mask. And so this isn't difficult for us anymore, just in the sense of we're always wearing a mask too. For droplet precautions, and you'll see some signage that I provide, the actual recommendation is not always to wear a gown. Many facilities will require wearing of the gown, but you'll see it's actually just mask and gloves for the droplet precaution and eye protection if necessary. We want to place them also in a single room if possible, because the respiratory droplets travel. This is a higher risk of other residents becoming infected. If it's not possible, then you're having that greater than or equal to 3 feet of separation with a curtain between beds. You would don the surgical mask or N95 respirator upon entry into the resident room, and then also making sure that they're wearing that close to the infected resident and patient. You would don the mask prior to the room entry. Oh, we have that twice. But you also, if a resident is being transported outside of the room, we would ask that they also wear a mask that will help protect the environment and potentially putting other residents at risk. So for airborne precautions, these are infectious agents. Again, in long-term care, we have traditionally not had to be too concerned with this, but these are some types of infectious agents. We have the measles, chickenpox, we have tuberculosis, and now, of course, SARS-CoV-2 and SARS-CoV. We want to have them in an isolation room that has negative air. Very few of our facilities, I would say probably less than 1% in the country, have this capability. And so with SARS-CoV-2, we've actually just modified it to contact droplet, and we're wearing the N95 respirator as well. So if possible, we want to transport or move the resident out. And I'm not going to go too much into this, but if you do have the opportunity, or you're building a new facility, or you're doing any type of reconstruction, here are the guidelines you want to be able to implement for an air room. You would have 12 air exchanges per hour for the new construction and renovation, and then 6 air exchanges per hour for existing facilities. So this is something you would work with your maintenance team on, the construction team on. And again, I know many facilities are in construction, they're building new buildings. So this may be a great opportunity to implement at least maybe 1 or 2 of these types of rooms. So respiratory protection program, I would say that the majority of facilities that I visit now are really great about this. We have slowly moved over the last 1.5 years into being able to have this respiratory protection program. It is an OSHA requirement. OSHA will fine your facility if you do not have this program in place. It is required if we're wearing any N95 respirators. It includes being able to do a medical questionnaire that basically assesses each person's ability to wear the appropriate N95 respirator or PAPR. So here is The requirements, you want to do fit testing at least annually. When using a brand new respirator, you want to make sure that the user actually they successfully pass. If they do not pass this, then you can try other masks or other respirators first. And really the worst case scenario is not having that individual be able to perform duties or responsibilities that require the respirator. So fortunately, we're in a situation now where we have more supply than we did a year and a half, 2 years ago. And so if you have staff that are having difficulty passing, maybe consider a different type of N95 respirator. I want to shift into enhanced barrier precautions. So until last week, I was really an advocate of it. I still am an advocate of it. I think CDC recommendations have gone to a little extreme, but I understand where they're coming from. So, multi-drug resistant organisms in our long-term care facilities are a major problem. There are antibiotic resistance is a major problem. And as many of you know, many times you'll get a resident that there is no communication with your hospital partners if they have a multi-drug resistant organism. And it may be days and days later that you're sorting through the chart and you see, oh, they have CRE, and you weren't even aware of that. And they may be colonized with one of these multi-drug resistant organisms. MDROs and antibiotic resistance is a global public health problem. It is a major problem, and we really do have to take action. So enhanced barrier precautions typically is we're using this expanded PPE when we're going to come into contact with a resident during high contact resident activities that could potentially spread this microorganism. And so we'd wear gown or gloves. Now, the reason enhanced barrier precautions came into place is, and it's really geared towards long-term care, is because in our hospitals, the guidance is they stay on isolation. And they're actually not even isolated all the time if they're colonized, but if they have an active infection or even colonized in some incidences, they will be isolated until they discharge. Well, we don't necessarily discharge them in long-term care. And so this is why we have introduced it. And in 2019, the CDC introduced guidance for our novel or targeted MDROs. And you can tell I actually created these slides before last week's guidance because these were the novel and targeted MDROs. Now it has been expanded to MRSA, CRE, other MDROs, and not only just for if somebody's colonized, but even the recommendation is to wear PPE during resident care activities for all residents with any intravenous lines or even catheters. So I know that's a bit to take on, but we're working through that right now. I didn't make up that. I didn't come up with that. So here was that. Actually, you can see July 12th, 2022, just a few days ago, was the updated guidance. So definitely, if you have not seen this or you're not aware of it, please look at this. It is a recommendation at this time. I know that there are great discussions happening at the national level. I just even yesterday learned CMS is working with CDC and ACA and identifying if this is going to be something that the surveyors are going to be looking for, or if this truly is a recommendation and facilities have autonomy to implement this. So more to come with that. So we just talked about this, the difference between contact precautions and enhanced barrier precautions. Contact precautions are required every time, regardless of the care being provided. If you walk into that room, you need to wear a gown, you need to wear gloves, dedicated equipment used for that resident, and the resident are restricted to their room because we don't want them to potentially infect other residents. The enhanced barrier precautions, the recommendation is to wear a gown and gloves when performing the high contact activities, residents are not restricted to their room and do not require placement in a private room. They can participate in group activities. And it's intended because of the long-term approach of these individuals that may be colonized. So here's some examples of some signage I just wanted to provide you. I did put in the enhanced barrier precautions, as well as special enteric for C. difficile. This is, again, it's helpful for staff. You know, I think when I think about my education, I mean, most nurses are going to know to wash their hands with soap and water. But, you know, when you start getting into your ancillary staff, the housekeeping staff, food service, laundry service, this isn't something they're thinking about all the time. So having this special signage is really important. Also for visitors, it's really important because we want to have these signs available. If you are still practicing that you just have C nurse on the door, I would highly encourage you to utilize the signage. It does not violate HIPAA, and it really, really helps for people to understand with pictures exactly what they need to use when they go into these resident rooms. A couple more for airborne, you can utilize these signage. Influenza, here's the droplet. You can see here, it's of course for hand hygiene, wearing the mask, and if needed, then you can wear the eye protection, the gown, and the gloves. But the mask is the most critical for the droplet precautions. For COVID, here's some special signage. Everybody has signage now for COVID and quarantine, so it's just some extra signage there. A couple ways, I know I'm going over, so I'm going to kind of speed through these really quick. I just want you to keep in mind the how to implement transmission-based precautions. Here's an example, having the PPE bin outside of the room. I would encourage you to keep the N95 respirator and eye protection at one of the top bins. If it's at the bottom, I've seen it get skipped. And so having it at the top, you know, kind of the order of what you would wear it, you'd wear the eye protection, the N95, the gown, and the gloves. So kind of having it in that order, making sure that you have somebody assigned to actually stock this PPE is really important. You know, if it's everybody's job, it usually doesn't happen, or I find empty bins. And then also having the trash receptacle inside of the resident room. Here's just a couple other tips, just making sure you have that stocking plan, appropriate signage. All of this is important. If you're using a cleaning agent to clean the eye protection, make sure that's available, and just hand sanitizer and all of that is easily available for anybody going into that room. So here's just how do you know if it's being successful or not? You want to continue to provide audits and provide education for when you see that these are missed opportunities. Consider having secret shoppers, people that can actually identify the correct usage within if this is being correctly done. We want to make sure that you're not reusing gowns. This is especially true in the laundry, where we love to reuse our dirty soiled gowns in laundry. But we want to make sure we're not reusing any gowns at this time. If you still have hooks on your doors, I would encourage you to remove them, because this will help to avoid reusing the gowns. So today we reviewed the infection landscape in long-term care. We discussed the difference between standard and transmission-based precautions, including providing some tips to implement safe and effective transmission-based precautions. I just want to remind you that I wrote a book that supports long-term care. If you haven't got a copy, I encourage you to do so. It really is a book on advocacy and all of the hard work that you as healthcare heroes have been doing during this pandemic, and really the steps that we move forward to implementing evidence-based infection prevention and control in our facilities. And then I will turn it over to you. I truly thank you for letting me share. It is such an honor and a privilege, and I will turn it back over to Kim.
Thank you, Dr. Buffy. I really enjoyed your presentation, and I found so there were so many great tips that nursing homes can use. It took me back to my days when I was there and going, oh my gosh, why didn't we do that? Or how simple just to do that. So I really appreciate that. Um, so now we have about like 15 minutes left, and does our audience, our participants, what kind of questions do you have for Dr. Buffy? Please just unmute yourself or go right ahead and type them in chat. That's fine. While you're thinking about those or putting your questions in, Dr. Buffy, I do have a question. I'm meeting with a nursing home in the near future, and they're telling me that they're using UV antibacterial lights to kill infection. And I'm not quite sure how or in what kind of way they're doing this yet, but do you have any input on that area?
So that's really great that you bring that up. It's the second time this week that I'm hearing this. And so I'm thinking this is starting to infiltrate more in our long-term care, which is it actually is an effective process of killing microorganisms. And we've been utilizing this in hospitals for a long time. However, it can be quite costly to purchase this equipment. And so in long-term care, we haven't traditionally seen it. But yes, the UV rays, the lights actually do kill and destroy the microorganisms. So what I would say to you is it has to be, so every surface has to be, has to have that direct UV light. So for example, in hospitals, you'll have a UV robot. And so say after a patient's discharged, everybody leaves, and that robot will literally scan and kind of zap every inch of that room. And so what's important to know, and it'll be interesting to find out, and I'm happy to follow up and learn more too of how they're using it or what equipment they're using, but the actual equipment or surface has to have that direct UV light. So if it's just beaming everywhere, like just, it's in the room, that's not going to work. So just keeping that in mind. But that's exciting because that is a technology that is effective. And I truly believe if we can take the human element out or reduce the human element as much as possible, then that can help us reduce error or reduce the risks because of all the other challenges that come with that, time and that. So that's exciting to hear, and I look forward to how that works in the future.
Yeah, thank you. I'll be interested too when I talk to them to see how they're using it. I'll let you know.
Yeah, great.
For sure.
I have a couple questions, and I want to hear from our audience a little bit. And there's a couple different ways I'd like to hear from you. The first one would be, we went over a ton of different precautions that you can be taking or you should be taking. What are the most difficult for your teams to follow or keep up with? Could you guys put some of that information into the chat? Or alternatively, what are some precautions or some tips that Dr. Buffy shared today that you're now going to implement? So pop some of those in the chat for us so we can start seeing those. I'm sure we all learned something new today that we want to start using. Give everyone a couple seconds to add some of those in. Wearing eyewear. Thank you, Wendy. See a couple more coming in. Okay, I know you all have something new that you're going to implement from this presentation, or I know that there are some pain points out there that you feel like you're constantly reminding people like, oh, make sure you're doing that. Testing per CDC routine testing requirements, that's a hassle. Yes, I'm sure. And just keeping up with everything, that's really difficult. And I know Dr. Buffy explained during the presentation as well. Did anyone not know about those new quarantine? Well, not so new, they're earlier this year, but was anyone surprised by those quarantine guidelines? Are we not following those yet? And now you will have some more flexibility because of those. Is anyone surprised by that? maybe not so much, and that's a good thing. We're glad to hear that you're able to keep up. It's really difficult to follow everything that's being put out there and to keep up with all of the new guidelines, just like Dr. Buffy explained. There's that new enhanced barrier precaution recommendation that just came out on the 12th. And that's kind of where our team comes in, and we're trying to put that out to you so you can keep up with that. So I'm glad to hear it sounds like a lot of you already knew about those quarantine guidelines. Another thing, and please feel free that if you start thinking of questions for Dr. Buffy, you can unmute yourself or put them in the chat. See, Angie wrote, N95 masks remain the greatest frustration of my staff. And the updated EBP guidance is a lot for facilities to take in and interpret. Any suggestions, I guess maybe starting with Angie's remark about N95 masks. Does anyone have any tips or tricks that have helped explain kind of, or helped encourage staff members about those and ease frustrations or things like that? Or Dr. Buffy, have you had any? I'm sure you've seen that as you've done site visits, that people are just really frustrated with those and been wearing them for a long time, and you didn't have access to them at the beginning, and it's just got to be really frustrating. So any tips on that?
Well, I guess my question to Angie is, what is your policy for wearing the N95? Are they wearing it all the time? Are they only wearing it into rooms with the residents that are not up to date? And so, the frequency is what it creates the challenge. And so I know that for even high transmission rate, it's okay to wear the surgical mask and eye protection, that is acceptable. And so hopefully, unless you're in a bad outbreak, then the only time you're having to wear those is in a situation where perhaps not up-to-date residents. I also know that it's frustrating because it's a very difficult piece of equipment to wear all the time. And so this is where it's really important to making sure our staff are properly fitted and that their respirator fits them very comfortably. If it doesn't, it's going to create all sorts of challenges for sure. So I guess the frequency and how often you're having to use the respirator is a question I have for that.
Yeah, Angie, if you want to unmute or add that information to the chat, feel free to do that. One thing I will mention with Greta's point with the EBP guidance, I know Dr. Buffy, you mentioned how you're going to be doing some research on, like, are these truly recommendations? Are they going to be something the surveyors are looking for? And we'll keep in touch with Dr. Buffy and learn from her on what she's learning on what that landscape looks like moving forward. I see another question here. Residents under quarantine, what is recommendation to keep up with ambulation programs? Should staff be allowed to ambulated resident in an empty hall while in full COVID-19 PPE?
So that's a great question. So the recommendation is to have any resident that is on quarantine to remain in their room with the doors closed. So that's the CDC recommendation. Now, because I mean, this is a unique situation where we have empty hallways now. And so I would have you walk through some risks with that. So anytime we kind of step outside of what the recommendations are, we should conduct a risk assessment or evaluate the risks. So for example, do they have to walk, do they have to walk, you mean outside of their room? Are they going to be encountering other residents? Are they going to be, what is the risk to other residents, even if they're wearing PPE? So we have to kind of consider that, we have to consider the risk for that. I have not heard of or seen any facility do this, but that's not to say that it can't be done. So I would even check with your the HAI division, your epidemiologist, even in your county, just to verify that this would be something that they would be okay with as well. Given how punitive our environment is, it's always, anytime we go outside of the recommendations, I always recommend, following up with our county or state public health authorities too, just to make sure we're okay.
Thank you, Dr. Buffy. And it looks like Angie clarified a little bit on that N95 situation. So currently, N95s are worn with resident in quarantine if not up to date upon admission and in an outbreak. My understanding is that one positive staff on a household/unit during the infectious period. With this low threshold, we are in an outbreak a fair amount. And she clarified that outbreak status is triggered by just one positive staff person if one cannot eliminate possible exposure through contact tracing.
Right. Right. So yeah, I mean, so to me, it sounds like maybe you're having your staff wear the N95 respirators all the time, which is definitely going to create burnout and a challenge. This may not necessarily be so. So if you just have a resident that's come in and there has been no exposure, then you don't need to be on outbreak status if they've come in and they're admitted from the hospital or whatnot. So you may be able to reduce the amount that you're wearing N95s. I actually, the only time I see facilities where everybody's wearing N95s now is if there is a full-on like outbreak. So within the facility. So you're talking to positive staff. Okay. Yeah, I'm still not seeing facilities that are the whole building is wearing N95s anymore. So I would work with your county epidemiologist on reducing this, because I don't think you need to be at that level. Unless you really can identify that every single person was potentially in contact with that positive staff, that may be a different story.
Thanks, Dr. Buffy. And thank you, Angie, for asking that question. If you do need any further assistance with kind of clarifying things or anything like that, feel free to reach out to our team, and we can get you in touch with kind of some of our coworkers who are really focused on more the infection prevention side of things. And they can kind of help you out with that. So don't hesitate to reach out to us if you ever have or are in need of further assistance outside of what we're talking about within these calls.
Oops.
So Angie said, although this is not the clarification I received from our regional IP, I will again reach out to her.
Yeah, so that's interesting. Yeah, so I mean, we would definitely I would definitely encourage you to work with the QIO team too, so they can dive deeper into this, because I mean, this is just pretty general information, and there is a deeper dive that needs to occur here, because just from my experience too of what I'm seeing around the country, it's very, very rare. In fact, the only time in the last 3 months that I've seen an entire building wear N95 respirators is if there's like big outbreaks occurring, and then they're actually only keeping it to the actual area. So I think there's a lot more we can work with now. Of course, we have to assess the risk, and we have to assess who's potentially been exposed to. So I would definitely get more support on that, so that you can take a deeper dive and possibly reduce all that PPE and those N95s, because you're right, the staff will be completely burned out if they have to do that all the time.
Yeah, thank you, Dr. Buffy.
Oh, it also looks like we have another comment in chat that eye protection is the biggest complaint. And do you have any good tricks of the trade in oh boy, and maybe providing a better understanding of why we should do this?
Well, yeah, so eye protection is the biggest complaint that I see as well. And anytime I go into a facility, when I ask what their biggest challenge is, before they even tell me, I could say eye protection, because that's just the reality across the industry. A couple of things. So it's funny because I'm kind of hoping that the CDC will kind of back down on this a little bit, but I don't know how they can. It's very difficult to make these public health decisions when there's so many variables. So I just kind of want to put that out there too. But it's like 93% of our country is in high transmission right now. COVID is very active and actively transmitting. And so what happens is if you have, especially many of our residents are not necessarily wearing masks, and and when you're caring for a resident, they don't necessarily have a mask. And so if you're caring for somebody and they cough or they sneeze on you and it does get into your mucous membranes, your eyes, then you could potentially become infected. And so that's the risk. The actual recommendation is to wear eye protection while providing resident care. The challenge with that is that it's difficult to implement if you are, you're coming in and out of the rooms all the time and you encounter residents. So that's why doing it facility-wide is easier. I will give you a tip on cleaning the eye protection if you're using a Sani wipe or a harsher chemical that may be leaving a film. I had a nurse recommend to me the Lysol disinfectant wipes. They're the yellow canister. They are EPA registered and effective against COVID, and they don't leave a streak. So the staff do like those better. But as far as utilizing the eye protection, it definitely is a challenge at this time, but just continue to encourage the staff, and that it's one of those tough situations, but it can decrease the risk, but it's not going to decrease the risk entirely, for sure.
I know we're at the top of the hour, but just really quick here, Dr. Buffy. Stacy does indicate here on this chat that if the virus is airborne, it'll go around the face shield. So it's not really stopping anything. That's the argument they get. Would you recommend the goggle then, or how do you feel about that quickly?
So when we're in an airborne situation, and she's right, I mean, this is, if we, we're saying it's an airborne infection, but so typically what we would wear is a face shield, or so it's the tight sealing one. So in a real application, and this is not enforced, but we would actually wear the goggles that completely seal around our eyes, or a face shield that has like the foam that's completely sealed, not what we have, like can get particles down into the gap. So what we're using now is not appropriate. I will just say that, but it's what we're using. So that's kind of the situation we're in.
Great. Well, thank you again, everyone. We're at the hour. I appreciate everyone being here. Dr. Buffy, again, a great presentation like always. Thank you, participants, for all of your great comments and questions for Dr. Buffy. On that note, everyone have a great afternoon, and we will see you next week.